Can we have Dr. Anujit for membrane patterns of choroidal neovascularization on OCT angiography?
A very good afternoon. My topic is membrane patterns for choroidal neovascularization. Good afternoon. My topic reads membrane patterns for choroidal neovascularization on optical coherence tomography angiography. The authors do not have any financial interest in the subject matter of this presentation. So age-related macular degeneration is the leading cause of irreversible blindness in elderly. Clinically, it can be classified into a dry and a wet or exudative type, and dye-based angiography, including OCT, has been the gold standard for accurate diagnosis and classification of AMD. OCT-A or OCTA is a novel invasive technology that we use for rapid visualization of vascular plexuses from the ILM till the choroid. The purpose of this study was to evaluate the morphological patterns of choroidal neovascularization on OCTA in treatment-naive, continuously treated, and previously treated patients of exudative AMD. A retrospective study was conducted with all patients having choroidal neovascularization, and 46 eligible eyes were chosen. The inclusion criteria were patients that were diagnosed with type 1 or type 2 neovascularization secondary to AMD and in whom a membrane pattern could be identified. Those with prior photodynamic therapy, myopic choroidal neovascularization, CSR, or signal strength less than 40 were excluded. In the initial diagnosis was done through clinical examination and OCT, and signs of neovascularization on OCTA were noted as presence of subretinal hyperreflective material, pigment epithelial detachments, intraretinal, subretinal, or sub-RPE fluid. To classify inactive neovascularization, history of any active neovascularization that was treated with anti-VEGF therapy at least 6 months before examination with no signs of clinical activity on clinical examination OCT. Type 3 neovascularization was excluded because it may not initially involve the choroid. All patients underwent a comprehensive examination, and the anti-VEGF chosen for the study was intravitreal brolucizumab. Evaluation of the OCTA scans were done by 6x6 mm criteria with automatic segmentation, and in those patients that automatic segmentation was not possible, manually the lesions were segmented. So as described, the lesions were classified as a well-defined or an ill-defined pattern, where a well-defined pattern was classified as a medusa head as vessels branching in all directions from the center, a C-fan pattern where 90% vessels are branching, or a long dilated filamentous pattern. Ill-defined membranes were those lacking a distinct morphology but still had branching capillary loops with or without anastomotic loops. So they were classified into a treatment-naive, a previously treated, and an inactive neovascular membrane category at the time of evaluation. Statistical analysis was done by one-way variance and Pearson chi-square test, and a p less than 0.05 was considered statistically significant. So in the 46 eyes that were chosen for the study, 76% had type 1 neovascularization with an average age of 77.9 years, plus minus. Out of the 46 eyes, 72% had active neovascularization, out of which 70% of that population were already receiving prior anti-VEGF therapy, and 28% had inactive neovascularization. Once again, out of the 46 eyes, 64% had a well-defined morphology, out of which a majority were either medusa head or long filamentous pattern, and 36% eyes had an ill-defined morphology. So in our results, the most frequently identified membrane morphology was a well-defined, and in type 1 neovascularization, majority had a well-defined, as was in type 2 neovascularization as well. And there was a statistically significant difference in membrane morphology between the two groups. These are some representative images of the patients which showing seemingly inactive OCT but still having a membrane pattern on the OCTA. This is another example of a long filamentous pattern on OCTA, whereas the OCT is showing regression. So correlation of clinical activity has been studied previously, and C-fan and medusa head patterns have been reported previously. Some authors have reported other classifications like a loose net pattern or a dense net pattern. In fact, Ling et al. Had previously reported that poorly defined vessels could be associated with inactive or active disease as well. In our study, clinically active diseases had a well-defined morphology, but however, almost half the percent of the clinically inactive diseases on OCT also had a well-defined morphology. So this makes OCTA-based morphological patterns not always suitable and reliable for prognostication of these cases. Also, long filamentous patterns was included for chronicity of the disease. Also, there was no statistically significant difference between the presence of ill-defined membrane morphologies, and rate of ill-defined morphologies was lower in patients treated with anti-VEGF. So in conclusion, well-defined well-defined vessels patterns could be seen in both inactive as well as active neovascularization, and long filamentous patterns was associated with inactive neovascularization. My take-home message is that membrane patterns on OCTA do not always serve as clinically suitable prognostic markers or as an adjunct to OCT for prognostication of exudative AMD. These are my references. Thank you.
Earlier the studies was done, similar studies was done in the literature?
Yes, there are studies from outside that have been done, sir.
Okay. Dr. Pooja, anything?
So you say that getting an OCTA is not very helpful because whatever pattern you see is not predictive of anything. So what is currently, how do you treat your patients based on, do you use OCTA for your treatment guidelines or monitoring guidelines, or just doing the routine?
So currently we are using OCT and presence of subretinal intraretinal fluid, but the OCTA membrane patterns are not correlating with the clinical activity on subretinal or intraretinal fluid. So we are still using OCT.
Yeah, actually, if you saw the same patient along longitudinally, naive, treated, and went dry, you would see changes in the membrane pattern.
Yes.
You're seeing different patients. So when you see them, that's probably when you would see. Thank you.
Thank you, ma'am.